evening, everyone. This is Dr. Sonpal Dagash, ENT and Direct Surgeon, and today we have a special guest. Actually, this specific video I'm making for the neurosurgery aspirants for who are looking for 6-year DNB course. Uh, Hello, doctor. Can you give your introduction to the viewers and in which year you are studying and which hospital you are going through the neurosurgery?
Hello, I am Dr. Dhairya Boghani. I am doing neurosurgery in Jubilee Mission Medical College, Thrissur, Kerala. Basically, I am from Gujarat and I did my MBBS from Government Medical College, Bhavnagar. Now I'm in a fourth year of neurosurgery of a 6 years course.
Okay, so nice. So basically, he's doing neurosurgery 6-year course. He's in fourth year, and first of all, straightforward, I want to ask you a question about when we compare about 6-year course or 3-year MCH course or 3-year DRNB course, which course has clear edge as per you, which will be better as a career for the aspirants in NEET PG.
Yeah. Sorry, it was.
Um,
It was-
uh, did you hear my question?
yeah, sorry, it was a network issue. I couldn't hear. Sorry, can you please repeat?
So basically, I'm asking that um, what course is better for neurosurgery as a career in future? Like any aspirant is looking for. If just I want an idea in general that 6-year course in comparison with MCH 3-year course versus DRNB 3-year course in neurosurgery, which course has clear edge over the other two?
So, in my opinion, if aspirant is a clear that they want neurosurgery, like they are 100% sure, this is what they want in their life. Then 6 years course is far better, because generally exposure in general surgery, we are not like we don't get that much exposure in of neurosurgery in.
I guess there is some network issue.
Hello.
Continue.
Yeah, so basically the skills we learn in 3 years of general surgery are most of the gross skills. And the
Okay.
skills required in neurosurgery is mostly the microscopic skills. So generally it's not that much helpful in pursuing neurosurgery. Like uro, gastro, those branches have a mostly continuation of general surgery course. But
Yes.
neurosurgery looks a completely different entity. So that's why I feel if person is 100% sure, that should join neurosurgery. But on the flip side, if someone is not so sure of neurosurgery, then this is a 6 years course. You have to stay in one institute for 6 long years, and a lot of different brand specific things are there, that like your very hectic work hours, and patients are also like more of serious patients come in neurosurgery. In ICU,
Yes.
there are, so there is a lot of morbidity, mortality associated. So all these aspects are like, if you are not very much sure about neurosurgery, and if you join neurosurgery, there are high chances of you might drop out, because
Yes.
in 6 years course, I think there is a 30-40% dropout ratio. Only 60 to 70% of people who join 6 years course finishes the course actually. In
Okay.
my institute, two people has dropped out, and in my batch, I think 36 people joined in my year in 6 years
So
course.
apart
And only
apart from
20
passing rates of DRNB, there is the major issue about is main thing is
drop
about
out.
dropout rate. Okay.
Yeah, so out of 36 people join in my batch, only 21 are doing the continuing at present in fourth year. 15
Yeah.
has left. So if you are 100% sure, definitely you will finish up the course, and it will be very nice because you can get 6 years of neurosurgery exposure that feels unmatchable.
So basically, I'm getting an idea about whatever you said that 6-year neurosurgery course has definitely a clear edge over any 3 year course like MCH or DRNB post MS,
Yes, yes.
whatever you do, it has a clear edge because neurosurgery is a vast field. Hai na? It doesn't only, it's not only about trauma, it's not only about spine, it's moreover about microscopic surgeries also, tumor surgery, which
Yeah.
I don't think so. I also belong to like similar kind of specialty, ENT I am doing. So it also has many microscopic surgeries. By that I can understand that microscopic surgeries are really having a long learning curve rather than that cross surgeries. So what are all the uh, future aspects of neurosurgery? Can you just elaborate in a smaller way, like a trauma hai, then that spine hai,
Yeah.
microscope, what are all the topics?
So basically, trauma and spine. These two are the main like for the initial period. You will learn trauma and spine. They are the main two bread and butter for the neurosurgeon. Then when we go ahead, onco neurosurgery, like all type of tumors, skull-based neurosurgery, that also includes most of tumor. Then
Hmm.
vascular and endovascular neurosurgery,
Hmm.
and that are the main areas. Apart from that, there are few areas which mostly require fellowship and specialization to master.
Hmm.
This includes functional neurosurgery, pediatric neurosurgery, and
Hmm.
this
Because
epilepsy neurosurgery.
the epilepsy, it also covers that surgeries for epilepsy and Parkinsonism recently.
Yeah.
So
So
for
that
that, I
functional
guess,
neurosurgery includes that Parkinson, DBS surgeries. So most
okay,
of times you'll require different fellowship for learning those skills.
okay. So it's a long journey. So I guess whatever you said, I'm getting through it. So it feels like post MS, if you do neurosurgery, it will be a long, long path.
Yeah, definitely. So that's what my concern. Like it takes 8 to 10 years to become a good neurosurgeon.
Yes,
At the
exactly.
end of 6 years, most of us, or at the end of 3 years in 3 years course in MCH, the operating skills we get is trauma, spine, and superficial tumors we can remove. That much only generally people will get in any institute.
Exactly.
Apart from aneurysms and all these skills, you have to learn afterwards. Like you have to practice more and learn. So it's a long pathway. 8 to 10 years it will take. So if you start early with a 6 years course, you definitely get an edge.
So definitely. On and any drawback of not doing basic general surgery or like surgical field, no experience in surgical field, and
Uh,
directly
two
surgery,
things,
is there any
two
drawback or
things I
not?
can make. Yeah, two things I can make out. One is in initial period, like neurosurgery is a specialty, so training is more tougher. When you get into general surgery residency, it is
Hmm.
little easier. You get absorbed easily. But in neurosurgery, when you join neurosurgery directly, it get little tougher, exhausting in first year, especially first year, second year. It is little difficult. That is the one part. Another part is maybe in a surgical field, like because in general surgery, if you go into general surgery, like within 2 3 months, you start getting some small cases, suturing. That maybe in intensive also you might have done some basic skills, but in neurosurgery you won't get
Surgery hands-on.
hands-on in initial period. So
Definitely.
maybe that basic learning part might initially you might feel it's not happening, but eventually you will learn both of them. Like eventually if you are joining singing, you will feel exhausted in first year and second year, but then you will get absorbed. You will learn how to deal with all these things, residency things, and also you will learn the basic skills of suturing and putting drain and all that. Is not a very big hurdle, but maybe in initial part people might feel that okay, I might have done general surgery, then it might have been easier.
आपको if you have any idea like जो जितने भी dropouts हुए हैं, in which year their majority dropouts are, have you seen, like if you have any idea?
Mostly first year and second year,
So,
because they
so
don't
it
like the branch
clearly
at all.
uh,
They don't
so it
cope with.
seems that that lack of hands-on initially might create a frustration in residents' mind, or if at all they are not they have taken by chance, you know, not by
Mostly
choice.
they have taken by chance, and more than chance, most of people join like they don't to skip the SS exam. They're not
Okay.
interested in surgery, but they join because they want to skip the SS exam. Then they
Hmm.
come and see, oh, this life is very tough, and they can't cope up with that. That is the most important reason I have heard of. Lack of hands-on is not a generally cause, because most of them we would have seen their fourth year, fifth year seniors doing cases, and also they know that eventually before coming out they will be
You will get hands-on, of course,
confident
because
enough
this is
to
long span. You will eventually have a good rapport with your
you will have
consultants.
your chances. Yeah, yeah.
So, talking about like saturation in neurosurgery, is it something real or like it's like in every medical field, like people talking about saturation?
Yeah, so I think saturation is nowadays real for each and every branch, especially in metro cities and major cities of India. But I think it depends more on your own skill set, because, as I told, neurosurgery is a very vast specialty, and you have to get trained for many years. So, and a lot of special things to learn, like if you have some specialty, if you learn endoscopic spine, or if you learn good MIS spine surgeries, or you know endovascular surgeries, you are better in some aneurysm clipping, vascular neurosurgery you do. So if you have some specialty, or you practice under someone and gradually go up into hierarchy and become a senior, then you can always like find your place. Situation is there. I'm not denying it that it is not there, but I feel like everyone can find their own places. It's not like we don't get jobs.
So, talking like about now earning potential, which is also related to saturation aspect also. So, what is the matlab, if a fresh neurosurgeons get passed out recently, then
Yeah, so
what can he expect?
generally in southern states it's a little lesser, like 3 to 3.5 lakhs is the initial salary. In northern state mostly 4.5 to 5 is the initial salary, but that depends mainly on where you are settling. If you are working under some other senior neurosurgeon as a junior consultant,
You might
and
get more.
in a bigger city, then maybe your salary will be lesser, but you will get exposed to more number of cases and more variety of cases. If you
Hmm.
go to peripheral center, your salary might increase to 1 or 2 lakhs or 3 lakhs maybe. There are people, my one of my senior has joined, who is earning 7 to 8 lakhs per month just after passing out. Okay, so it depends on you. But if you are joining in peripheral center, maybe you will get mainly trauma and spine only in initial part. Then
No,
later
no,
on
no,
you
of
will get
course.
exposed to. So that depends on where you want to practice.
And what are the matlab, what is your insight about uh, setting your own setup? Like if you put your own setup in
Uh,
neurosurgery, is it
I think no neurosurgeon will want to like put their hardly and sleep at like because see, if we put our own setup, means we are in on duty 24 into 7, and neurosurgery may almost 80% of cases are unplanned. Rarely
uh,
we give the dates and they come on that date, maybe spine cases,
hmm.
non-traumatic spine cases, or non-coda equina syndrome, like those type of, or maybe some tumor will get date after 2 3 days or 1 week, something like that. So it's always better to have a team in a neurosurgery, especially once you become more senior. Like you will want a team to work with so that you can find out time for your family life and all. So generally, by default, neurosurgeons don't prefer to start their own setup, and they like to work as a team in most of scenarios. But if you want to start your own setup, if you're adamant about that, then it's very costly, because all the instruments like microscope will cost you the 3 4 crores. If you go for navigation, maybe 2 3 crore for navigation. So, and OT setup is a instrument, everything is very costly, plus you have to have the robust ICU setup, pre-op, post-op, and ventilator setup. So it's very costly, so it's difficult to set up. But mostly I don't feel anyone would want to do their own practice, except they become very senior and they can afford to give a job to another 3 4 neurosurgeons. If someone
Hmm.
is to level, then okay. Otherwise, alone, I don't think anyone will want to do
Yeah,
it.
yeah, of course. It's quite difficult. So,
Yeah.
some questions are there. If you can read out,
Mm.
you like the last second last question.
If a patient is psychologically unstable, then better not to go for awake brain surgery. Even if it is in a critical area, we can put a neuro monitoring, which is a indirect way of measuring the area, and we can always go with our own anatomical knowledge. We can go with a functional MRI pre-op. We can try to avoid damaging that area with other things than awake surgery, because awake brain surgery requires a very good amount of cooperation from the patient.
Okay.
If
So,
HIV patients, I think you can always use the PP and do surgery or whatever. Like,
okay. So, one more thing is there. Like many questions are about. Like I'm getting recently DMs and comments about people who are taking ENT. Uh, with the plan of taking neurosurgery post MS or DNB after ENT. That is also eligible recently, and that is in the PGMA notification. Also, that NEET SS 2025 also notifications clearly mention that ENT is eligible for neurosurgery. So, those all aspirants who are planning to take neurosurgery post MS or DNB ENT, um, if you can compare out, see, you have done 6 year course, so you can be neutral judge for both the things, like uh,
yeah,
MS general surgery is better or ENT is better before going into neurosurgery. If one plans to avoid 6 year course and do neurosurgery post MS, so which would be better?
I think both are almost similar, because you are not exposed to actual neurosurgery as such in any of the branch. Even in general surgery, the part you are exposed to is a trauma. I think that is the only part you are exposed to. You don't know about spine and onco and all. And in ENT, maybe you are exposed to skull-based surgery. Another advantage ENT might have is the microsurgery, because you also operate with a microscope, and so that part might be there. But in that case, another thing is like those skill set is different for neurosurgery completely. So I think both
Different
are
from both
same.
the.
Yeah, yeah. So definitely you will have some advantage, but definitely like you have to at least practice few years into neurosurgery to get into neurosurgery. So I think
It's
both of them can
basically
join
different
it.
from both the
Yeah, yeah,
specialities.
both of them can join if they are interested into. They can definitely join.
Like I've seen many, like almost all the MCH courses are actually not all the courses are actually super specialty. Many are subspecialties, but I've seen, like what I have experienced, I've worked with many neurosurgeons in practice, because we generally have to deal with head and neck trauma. I also do maxillofacial trauma and all. So in their experience also, they've told that uh, neurosurgery is like completely different from both the fields.
Mm. Yes, yes. And I
So
think one more, like I think two more aspects I will just want to clarify. One thing about take as we talked about this dropout and all. Okay, so I just want to clarify that in neurosurgery, if you are 100% interested that you want to do neurosurgery in your life, then you will get like once you get into specialty, initially maybe you get exhausted, but then you will understand the real feel of it, the adrenaline rush, the patients coming back to you with like improved outcome. You have seen them lying in ICU for even VTM1 for 6 months. They are coming to you in OP, walking, talking. They are like about to die. In their state, you saved their life. They are quadriplegic patients which will come to you walking, so that satisfaction will be higher, but it is like a time taking process. So you should have patience. Patients will take time to improve. You will have time. You will take time to learn things. So if you are joining a neurosurgery, you should be patient about it, and you should be like, if you are crazy about neurosurgery, then only I think neurosurgery is a good idea. Taking up neurosurgery 6 years is a good idea. It's a one aspect. And another aspect is about MCH versus DrNB. People are comparing, like maybe MCH people might get a better job and something, but I don't feel so, because see, MCH is practicing in medical colleges only, and government colleges only. There are few private colleges, but yeah, mainly it's in government colleges. So what happens in government is you don't have that much robust ICU setup, and because of the heavy caseload, you don't care much about the pre-op, post-op management, and the counseling part, decision making part. So mainly, like, maybe hands-on they might get better in the government setup, but neurosurgery is not only about hands-on. It's about the finding out your right candidates to operate, taking decisions when to operate, when not to operate,
And
which approach to go, and properly counseling the patient about the post-op outcomes, complications, what they can expect from the surgery, and managing all type of post-op complications. So these things, I think DNB people are more well versed in it, because they are working in a private institute where people are paying hefty amount to get operated. So definitely their consultants are more like
so the approach is
more into.
not only like so approach is not only about that academies, right?
In the end, about job, I think I don't think anyone will differentiate in a corporate setup when you are joining that you are whether you are DNB or whether MCH, because corporate setup is all about money. So when you go to a big hospital as a consultant, they want like they'll give you salary of what you are earning, what you are generating, like 20-25% of what you are generating. They will pay you. That's the truth.
Yeah.
So if you are generating 15 lakh for them, they will definitely pay you 3 lakh, 4 lakh rupees. That's the truth. So it doesn't matter if you are DNB or MCH. And in India, about patients, 90 more than 90% of patients doesn't know about like neurologist versus neurosurgeon, even versus psychiatrist. They just know he's a brain doctor. So
Yeah.
they won't know about MCH or DNB, and they won't care about it. So I don't think it matters, but it matters only when you go for fellowship outside, and there DNB has a little bit more edge over MCH, because we have structured exam in DNB.
Hmm.
So when we go for fellowship or outside India, then maybe DNB will have might like small edge over the MCH, because of the structured exam pattern and structured learning pattern.
Okay.
In a job in a government setup, maybe MCH people will get more absorbed into their own department after doing their 3 years course. This is a small edge, but those are the mainly differences which can happen.
Okay. So what all the exams you have to give in that 6 year during the span of 6 years? What all are the necessary compulsory exams that you will have to give?
So we have divided into two parts, part one and part two. So
Okay.
part one exam is given at the end of 2 years, and part two at the end of 5 years. So in part one exam, we have 50% of general surgery, 50% of neurosurgery, theory and practical both. And in part two is pure neurosurgery. So the combined, you have to pass your part one before giving part two, and part two before you end your course. So generally, what happens is at the end of fifth year it comes. So you get one more chance. Even if you fail, you get one more chance to give exam again. So generally, in neurosurgery, like before 6 years, almost everyone pass out. So
Yeah.
passing is not a big issue for neurosurgery.
To
You
stick
get
to the
another
six
chance.
years is more important, right? Rather than passing.
Yeah.
Okay. So you told that part one exam is majorly about 50% general surgery and 50% neurosurgery. But within those first 2 years, are you exposed to general surgery or you are directly taken up in your own department?
Yeah. So ideally, we have 1 year of posting into general surgery. In
Okay.
the DNB curriculum, it is mentioned, but most of
Hmm.
hospitals hospitals don't
Don't
give it.
follow
They mostly give for either 3 to 6 months is the general norm. Some hospitals don't give it at all. But in that, like say, general surgery theory paper is more about like general part of general surgery. So basically, 80% of things you would have read in your MBBS final year exam. So theory exam is not that difficult to crack, and practical exam is also like OSCE pattern in general surgery. In neurosurgery, you get Viva. General surgery, you get only OSCE pattern. So you can read your theory and give your exam. So lack of exposure in general surgery is not a big factor for passing exam. Basically, we all focus more on general surgery than neurosurgery to pass the exam. We get like 60-40, 100%. We get try to get 60 marks from general surgery paper and 40 from neurosurgery to pass the part one exam. It is that easy to get marks in general surgery.
Okay, so otherwise, I don't think so. If anyone have done 5 years into the neurosurgery, the exit exam that part two will be difficult for anyone,
Yeah,
right?
a lot of people fail in first attempt, but they
But
clear in
still,
second attempt.
yeah,
So
yeah. Okay,
eventually,
just
it
answer.
don't add up in your years as such.
So in national board examinations, like in general, they have repeat exam also within 6 months only. So you can catch up and within
Yeah,
6 years you pass. Yeah.
you will pass and
So basically, what all conclusion I have drawn from our discussion is like 6 year neurosurgery course has definitely a greater, much more edge than a 3 year MCH or 3 year DRNB course post MS general surgery or ENT. So and the amount of variety of surgeries that is been exposed within 6 years is much more than any 3 year course. And one more thing I want to ask that what are all the future aspects to look for in neurosurgery which have brighter scopes, like trauma is all age old thing, like we all know trauma is there, and apart from trauma will be there. Apart from trauma, what are the brighter aspects in future, next 15 to
so
20 years?
yeah. So I will just elaborate it a little bit because most of people will have some doubts. So it are like three options for you when you come out after 6 years. One is either you go to peripheral center and start as an independent neurosurgeon in big setup. In that case, maybe you can survive with basic trauma, basic tumor, and basic spine. Then, and you won't have much of the competition around, so it will be fine. Then another aspect, maybe you can work under some senior neurosurgeon to get more hands-on, more confidence over the years. And then once he retires or once he give you the position, gradually you fill up his space, and you can become a senior. And third pathway is to do a fellowship. So what I feel like either if you are like either if you want easy money but you are not concerned much about like go doing the very complex cases and all, then peripheral center might be the better option because you start earning a lot of good amount of money from beginning itself. But if you are into the doing more complex surgeries, then either, as I told you, work as a junior or you go for a fellowship. So in fellowship, like if you learn some good skill in fellowship, like endoscopic spine. Earlier, the spine surgeries used to be like very big surgeries. Patient used to stay in hospital for 1 week, rest for 3-4 days. 1 month they will be almost bedridden, just in mobilization. Nowadays, with MIS tubular and endoscopic spine, you mobilize the patient by night itself for next morning, discharge them on next morning. They get back to their own work within 2 days, 3 days of surgery. So then this minimal invasive brain surgery is endoscopic, like they do keyhole aneurysm surgery and all these things. So if you can specialize into something, then it's always better. Like you can practice in that area. Then situation won't touch you, and you will have your own set of patients. Even other neurosurgeons will refer to you because for difficult cases. So that fellowship is one of the good options.
So endoscopic spine has a brighter future, right?
Yeah,
And
endoscopic or tubular MIS, both are almost giving almost similar results.
any other aspect of neurosurgery that has
Yeah, then as I told, like vascular and endovascular neurosurgery. Nowadays, lot of endovascular procedures, intervention procedures are coming up. So it's a hybrid neurosurgery. So basically, for neurosurgery, it's very easy to learn that procedures because you are well versed of the disease, you are well versed of the anatomy. Only thing you want to learn is to get access to the endovascular process, like how to go from the femoral to basilar or femoral to ICA. That's the only thing you need to learn. So, like there are 3 month, 6 month courses, fellowship, or maybe 1 year fellowships which are providing a good endovascular exposure. Or maybe you work in some setup as a SR where they are doing a lot of endovascular procedures without fellowship. That also is a fine. So that is one of the very much emerging branch people are taking up.
Neurosurgery is eligible for all the endovascular surgery, interventional endovascular surgeries.
Yeah, yeah, yeah.
Okay. So with
Yeah.
otherwise radiologists they can collab with or they can do solo.
Yeah, the problem like radiologists doing for aneurysm coiling. Suppose they are doing that, they don't know about patient develop hydrocephalus, patient develop seizures. If it
Anytime
ruptures,
can pass. You have to keep neurosurgery in backup. So if
yeah. So it
you
is
yourself
always
are
better
doing
for
then
if like I'm putting a coiling endovascular, going and putting endovascular coiling. It if ruptures, okay, I was set up. I will just open up the brain and I will go open surgery at the same time. So I will have definitely better chance of survival for the patient. If some post-op complication also happen, we are as a neurosurgeon we are well versed with all these complications. So it's always better for a neurosurgeon to do this hybrid procedure. Then another thing is skull-based neurosurgery, like complex CP angle tumor, olfactory groove meningiomas, like skull-based surgeries are also very like popular amongst the neurosurgeons. And then other options which people generally like don't choose, but some people will get interest and they will choose are the pediatric neurosurgery. That's spina bifida cases, cranial synostosis, like all this type of pediatric cases, because it's dealing with pediatric surgery is not just about surgery. It's about pre-op, post-op management, all these things. So a lot of people are going into it, and pediatric, mostly pediatrics neurosurgery, like the specialists only generally do those surgeries.
yeah.
General neurosurgeons generally don't prefer to operate on them, except senior neurosurgeons, which who are like good exposure. Then functional neurosurgery like DBS, then pain procedures like trigeminal neuralgia, glossopharyngeal neuralgia, those type of procedures we are doing. Then DBS for movement disorder, Parkinson, tremor. Then epilepsy surgery. Then some people are in neuro-oncology. That is also like more about tumor. So those are the fellowship options, good fellowship options we get after neurosurgery.
So in neuro, it feels like neurosurgery is the best bet amongst the neurologist and interventional radiology who are doing in the neuro.
Intervention.
So neurosurgery is by far the safest option in future also because it has a lot of scope. Uh, Not like I guess CTVS surgeons, cardiothoracic surgeons.
I
Uh,
think they didn't enter into intervention. We
yeah,
neurosurgeons have identified the risk and from beginning
take the
itself we enter
conservative.
into the field and we are doing it. So
Because neurologists also can do the interventions, but what I have seen is neurosurgeons are very much interested into interventions. So
yeah,
it's better for future survival.
I think one question came about operating on eloquent areas, post-op deficits, and how to deal with those things. So I think it's more about counseling the patient, because when you see the scans, when you examine the patient, you know you expect some post-op complications will happen. If patient is walking today pre-operatively, but he might not be able to walk tomorrow. He will definitely have weakness. You understand that with your experience. So it's all about counseling the patient. You to tell the patient that if I operate, there are high chance like he might have weakness, but he will improve after the surgery because it will be because of edema. But if I don't operate, tumor will infect the area and definitely he will go bad post-operatively. So that more like most important thing in neurosurgery, I feel, is a counseling part
Okay.
about complications.
Definitely, when you are dealing with life and death scenarios, counseling is must. Uh,
Yeah.
so I guess there are no any more questions, and I guess they will questions might come after we end up the live sessions in the comment section. So we'll answer that in future. But so we will end up wrap up this session about neurosurgery, and I hope you have gotten a clear idea about by Dr. Dairya, and he has have some given some really good insights in neurosurgery in each and every aspects, like right from the starting of your career in the neurosurgery till you get you end up with a job or start your own setup or anything. So it was nice to talk with you, and hope we will connect in future also.
Yeah, thank you so
Thanks.
much for
Thanks
inviting
for
me
your
here,
valuable
and
time.
it was nice interaction. Okay, thank you.
Okay, thanks.